Hello everyone, Steve Zuckerman in Baton Rouge, Louisiana, here to talk to you today about a little bit of Parkinson's disease. And here he is, Dr. James Parkinson himself, who is credited with the description of Parkinson's disease in 1817, ironically at the age of 62. I say ironically because that is the exact age I am now. And here is a reproduction of Dr. Parkinson's essay on the shaking palsy. If you click anywhere on the page, you may get a sense as to how difficult it may be for someone with Parkinson's to read that essay. But in any case, it was until more than a century after his description of the condition that in 1919, neuropathologists described an atrophic substantia nigra found in patients with Parkinson's disease, and 140 years after his initial description was dopamine discovered as a neurotransmitter. In 1960, they discovered the striatum was deficient in that neurotransmitter, and in 1961 were the first trials of injectable dopamine for the management of Parkinson patients. This slide is included to separate the men from the boys, the women from the girls, the men from the women, or whatever combination you'd like. But if you are interested in learning more about the anatomy and the physiology of the basal ganglia and how that all works together as feedback loop circuits, by all means, be a nerd. Otherwise, just say you're not interested and I won't be offended. Here is a depiction of a sagittal section through the basal ganglia showing the important anatomical structures. And these include the caudate nucleus that, along with the putamen, make up the striatum. Then you have the globus pallidus externa and interna. At the bottom are the subthalamic nucleus and substantia nigra in the midbrain. And finally, the thalami, the thalamus on each side, project back to the motor cortex, which would then complete the loop. The input into this system is all into the striatum and is excitatory via the neurotransmitter glutamate. All of the output from the basal ganglia comes via the globus pallidus interna and is inhibitory using the GABA neurotransmitter. They feed back onto the thalamus for movement control. Here is a depiction of the direct pathway, which enhances movements and initiation of movement, and it begins at the motor cortex, which sends the excitatory stimulus to the striatum, which then connects with the globus pallidus interna using the inhibitory neurotransmitter GABA. The thalamus is under the inhibition of the globus pallidus interna. The thalamus will tend to be excitatory and increase movement unless that is braked or stopped or controlled, reduced by the globus pallidus. The effect of the direct pathway is going to be you will be inhibiting that inhibitor, and as a result you will have a relative release of the thalamus for increased activity. So motor cortex has the idea of movement, sends the signal to the striatum, which then further inhibits the globus pallidus interna, freeing up the thalamus for increased movements. Stimulation of the indirect pathway, on the other hand, stops any excessive movements, so that when the motor cortex sends its signal to the striatum and you then need to stop your movement, this indirect pathway is going to be called into play. So in this case, the striatum synapses with the globus pallidus external, which then signals the subthalamic nucleus, which has an excitatory control over the globus pallidus interna, and as a result, further enhances the inhibition or inhibitory signals sent to the thalamus, reducing the overall movement. And finally, this slide shows how the substantia nigra is connected to the striatum via the nigrostriatal fibers and can synapse in the striatum directly and stimulate the D1 receptors, which further inhibits the globus pallidus interna, increasing movement, or through an excitatory interneuron can stimulate the globus pallidus externa via the indirect pathway, shutting off movements. This latter is with a D2 receptor. I would like to welcome back those students who opted to go through the neurophysiology of the basal ganglia and welcome you as true students of medicine. And for you other people, really, I'm not offended. But let me say a few words next about the epidemiology of Parkinson's disease. There are just a few things on this slide I'd like to point out. First, that there is a slight male predominance of Parkinson's, 1.5 to 1. Second, that in people over 60 years old, the incidence of Parkinson's is 1%, which is not insignificant. And finally, risk factors for the development of Parkinson's. If there's a positive family history, there are genetic predispositions and causes of Parkinson's having to do with certain Parkin genes for ubiquitin. Pesticide exposure has been shown to be a risk factor. Head injuries, as in dementia pugilistica, and the other one is not true. A few words about the pathophysiology of Parkinson's. As we know, the disease is correlated with the loss of dopaminergic cells in the pars compacta of the substantia nigra, and that the pathophysiological hallmark of Parkinson's disease is the accumulation of Lewy bodies, so that Parkinson's is considered to be one of the synucleinopathies. A very interesting hypothesis has been developed based on observations that the Lewy bodies are present actually outside of the brain several decades before the brain is involved and clinical symptoms appear. So that the Lewy bodies first appear in the gut. They are thought to travel or propagate adjacently. So from the gut, it would go to the vagal nerve, and from there, it would travel to the olfactory bulb, which would then cause further dissemination contiguously to the adjacent brain areas. In this fashion, as it disperses, it's actually acting as if it's a prion. And so there is certainly this Braak hypothesis, which postulates that Parkinson's, due to the Lewy body propagation, may be as the result of a prion type behavior. And finally, we will discuss various clinical features. And as per the above discussion, there are both motor and non-motor features that are associated with Parkinson's disease. So under the category of motor features, there are 4 so-called cardinal motor features. Early on, these include slowing down of movements or bradykinesia. There can be an increase in muscle tone or rigidity called cogwheeling rigidity. There can be a resting tremor, which is the hallmark of the condition. And finally, later on in the course of the disease, there is loss of balance or postural instability, with retropulsion. Now, which of the cardinals represents which of the features is unclear, so I will leave that to your own imagination.
Here I'm going to show you a case of affected your movement. It has affected.
Here is the test for postural instability by pulling the patient backwards and seeing how well they can maintain their upright position. Another very useful diagnostic clinical sign is called the glabellar reflex, and that entails tapping the forehead and noticing whether there is a blink coincident with each tap. The normal person will blink maybe once or twice, whereas patients with Parkinson's disease or other extrapyramidal disorders will blink each time their forehead is tapped. The other name for that, the eponym, is called Meyerson's sign. And in the very rare case in which diagnostic uncertainty might persist despite application of your greatest clinical acumen, there does exist a nuclear medicine imaging study called a DAT scan, after the saints, Hudat, in which fluorodopa is tagged and has affinity for dopamine. So on the left, the normal person has enhancement in the normal configuration, whereas on the right you can see the relative paucity of dopamine-containing cells, diagnostic of Parkinson's disease. In the category of the non-motor afflictions of patients with Parkinson's disease, here is a list of the early non-motor symptoms, and they include loss of smell, and that is usually the first clinical sign, if recognized, of Parkinson's disease when it relates to the spread of the Lewy body involvement when it involves the olfactory bulb, fatigue, certain psychiatric problems, sleep disorders, and autonomic nervous system problems, including the constipation, which precedes the diagnosis, again, due to the Lewy body involvement before clinical symptoms may appear. In regards to the differential diagnosis of patients with Parkinson's disease, a lot of times there is some difficulty in distinguishing an essential tremor from the tremor of Parkinson's disease, despite the fact that there appears to be a clear-cut demarcation that Parkinson tremor should occur at rest and go away with movement, and essential tremor is the opposite. It should not be very present at rest and should increase when the patient is asked to place their hands in an outstretched position or do a finger-to-nose maneuver or utilize that limb for other activities. Also, within the differential diagnosis of Parkinson's disease are the so-called Parkinson's plus syndromes or atypical Parkinson's disease, in which there are extrapyramidal features that are usually associated with other neurological manifestations. And so, for example, in multiple system atrophy, there may be some cerebellar dysfunction or cortical spinal tract involvement, whereas in progressive supranuclear palsy, there is a disorder in voluntary eye movements such that down gaze is impaired, and also there's very early involvement of the axial musculature with very early involvement with postural instability and falling. Diffuse Lewy body disease is one in which there is a combination of both a dementia as well as Parkinsonian features. Listed on this slide are some tips which would give you a clue as to whether there is idiopathic Parkinson's versus one of these Parkinson's plus syndromes. If there is no tremor, it's suspicious that you're not dealing with a typical type Parkinson's, or if the symptoms are very symmetrical at their onset, that would be not typical of Parkinson's. If there's early onset of postural instability, and ultimately if they're not responsive in a somewhat dramatic fashion to the administration of dopamine, then it's highly questionable as to whether they have idiopathic Parkinson's. And now, what you've all been waiting for, treatment! Yay! Certainly the mainstay of treatment for Parkinson's patients is going to be a combination of Carbidopa and Levodopa. As you know, Carbidopa gets transformed within the central nervous system by dopa decarboxylase to become dopamine, and Levodopa inhibits that conversion peripherally such that it limits peripheral side effects and increases the efficiency of the Carbidopa that's contained in the medicine. Sinemet itself, or Carbidopa-Levodopa, usually is used at a 1:4 ratio. For example, 25 milligrams of Carbidopa and 100 milligrams of Levodopa, and is usually initiated at a half a pill to be given every 4 hours. Now, early on, while the patient still has dopamine producing cells, the dependence upon exogenous dopamine is less, so that timing is not as critical because there's still some minimal storage of dopamine within the brain. However, as the disease progresses, the patient becomes entirely dependent upon exogenous sources of the dopamine, and timing becomes pretty critical and important in that case. Usually Sinemet lasts no longer than 4 hours, and so a lot of times when doctors prescribe it 3 times a day, patients assume they're to take it in the morning, at noon, and then right before bedtime, and that is not the most effective way to use the medicine. Now, there are other formulations of that combination of Carbidopa-Levodopa. Sinemet CR is supposed to be a controlled release. However, it is not really absorbed on any sort of predictable basis, and so whether or not it's a successful strategy is unclear. Parcopa, on the other hand, is supposed to be a more rapid onset and short-acting medication, and then a newly produced medication, Rytary, is supposed to have more long-lasting half-life and duration of action such that it can be truly used at every 4 hours with less chance of end-of-dose motor complications. Finally, there's Stalevo, which is the combination of Carbidopa, Levodopa, and entacapone, which is a COMT inhibitor, so as to try and prolong the effectiveness of the dopamine at the synaptic cleft. A different category of medications include the so-called dopamine agonists, in that they don't require metabolic transformation to become active, they act directly on the dopamine receptors themselves, though not necessarily with the same affinity that dopamine does. These include the two major ones are pramipexole or Mirapex and ropinirole or Requip, and there are longer acting contributions to the market, Mirapex ER and Requip EL. The problem with these is that you'll have a lot of trouble getting them to be approved by insurance companies. Another dopamine agonist called rotigotine or Nupro is delivered via a transdermal mechanism, so that's a patch that is a little bit more convenient because it only has to be changed once a day. Within this category is also Apokin, which is apomorphine, which is an injectable form of medication, and the apomorphine is also a direct dopamine agonist and pretty nearly simulates what dopamine does. It's used when there is end of dose effect or the patient needs some rapid and transient boost in their symptom control. The MAO-B inhibitors and COMT inhibitors both work by prolonging the duration of the dopamine's effectiveness within the synaptic cleft by slowing down the breakdown of dopamine by the monoamine oxidase or the catechol-methyltransferase pathways. So within the MAO-B category are Azilect or Rasagiline and Zelapar, Selegiline, whereas Comtan is the most commonly used COMT inhibitor. In this other category are listed the anticholinergic medications, Artane and Cogentin, which are said to benefit patients with a tremor-predominant Parkinson's, though there is not a lot of literature data to support this contention, as well as Simitrel or Amantadine, an old-time originally antiviral medication which has also been shown to have anti-Parkinson properties. So why aren't all patients diagnosed with Parkinson's disease immediately placed on Carbidopa, Levodopa? Well, we want to try and avoid the development of motor complications, and the younger the patient is and the longer they've been on that combination medication, the more likely they are to suffer from these complications. Motor complications are typically peak dose dyskinesia, in which when the medicine kicks in they have excessive involuntary movements, or perhaps loss of effectiveness before the next dose is due, end of dose, wearing off effects, or wide fluctuations of motor control where there's on and off, or even freezing in which they suddenly become unable to move. Complications more usually associated with the dopamine agonists are these impulse control disorders in which the patient will become obsessed with something like shopping or gambling or going on the internet and looking at porn sites. It's a very dangerous and unfortunate complication which can only be managed by eliminating those offending medications. Given all of these different therapeutic options and potential for complications, there have been developed various algorithms. In general, if the patient is younger, i.e. less than 60, it's recommended that one does not start with Carbidopa, Levodopa, and perhaps even use an MAO-B inhibitor if the symptoms are mild and do not impair with function a great deal. As the patient gets older, and particularly if they're more impaired, there is the indication for the Carbidopa, Levodopa. Again, in the younger patients, you may want to start with the dopamine agonists, and perhaps later on, if there's lack of an adequate duration of the Carbidopa, Levodopa, some of these medications can be altered so that the medication may last longer, including even increasing the dose and increasing the frequency of the medication so as to cover the patient's symptoms maximally. Besides dopamine or dopamine agonist type medication, there does exist a surgical procedure in which there is the implantation of an electrode. This is a deep brain stimulator. Usually it's placed into the subthalamic nucleus, and this modality is reserved for patients who have shown a definite responsiveness to dopamine, and it's supposed to be considered electrical dopamine, and many patients have gotten very, very good symptomatic relief with their deep brain stimulator. Of course, it does nothing to affect the underlying disease, which is going to progress, and eventually over the 10 or 20-year course of their disease process, this also will become unresponsive. Another approach in an attempt to reduce motor fluctuations due to a variable absorption of the oral forms of Carbidopa, Levodopa is this so-called duodopa, which entails having a pump which is inserted like a peg tube with the catheter going into the duodenum, which delivers a Carbidopa, Levodopa gel continually throughout the course of the active part of the day in an attempt again to even out any motor fluctuations. This has been used for quite some time in Europe and fairly extensively, and I believe has been recently been approved in the United States, but I've not yet seen patients employ this method. And here is a ridiculously busy slide which lists the options to treat the non-motor symptoms. I'll just mention a couple of those, and that is hallucinations or psychosis. Of course, you can reduce or eliminate the anti-Parkinson medications, and then you'll run into more symptomatic motor problems. The two medications that tend to be used the most is quetiapine or Seroquel, but ultimately clozapine or Clozaril is the most effective. Of course, Clozaril can only be administered if the patient's in a program to monitor their white blood cells on a weekly basis so as to avoid a dreaded complication of agranulocytosis or neutropenia. The other complication of Parkinson's that's not uncommon is that of orthostatic hypotension, and I've been using predominantly midodrine or proamotine, but there's been recently approved another medication, droxidopa, for the treatment of orthostatic hypotension.
You show me?
Yeah.